All right. Hey, everybody, we're back at it again. We're going to be working it today with Major Tyson Sjulin. Dr. Sjulin, you're going to enjoy this presentation that he has. So here we go. And so the idea today is to actually have medical specialists, subject matter experts in the medical field, and especially concerning the current topic that we've got going on, which is COVID-19. But Dr. Sjulin, he's a well-rounded physician, and he's going to definitely bring and paint to you all a good image of what exactly an Army physician is. So let's welcome Dr. Sjulin. Here we go. Dr. Sjulin, how are you?
Good afternoon, sir. How are you?
Doing great. Thankful that you got the clearance and decided to come and join us and, help educate the public, help educate, future soldiers that are checking out your stream right now. And, looking forward to just hearing what you've got to present to us today.
Great. Well, thanks for having me.
No problem. So I know you came prepared. You've got a slide, and we're going to use the slide. We're going to show the presentation, but we're going to try to make this as interactive as possible. So if you're checking out this presentation, you can, in the comments section, leave questions, leave comments. At the end, we're going to have a question and answer session, of course. So, feel free to write as much as you want, ask questions as you want, because we're here to teach and educate you. So, sir, would you like to go ahead and let's begin doing our thing?
Yeah, let's go.
All right, let's do it. Here we go. Slide one.
So good afternoon. I'm Tyson Sjulin. I'm a major in the United States Army. I'm currently a pulmonary and critical care physician at Brooke Army Medical Center located in San Antonio. Let's go ahead and go to the next slide.
Mm-hmm.
Nothing to disclose, disclaimers. These are my thoughts and not the United States Army or the DoD. Next slide. So, if you guys want to leave comments, then hopefully you guys can help drive where you want this discussion to go. I thought we'd kind of go over my story and how unique it is and how I ended up in my spot. Kind of go over some benefits of the United States Army, especially when it comes to the military and the medical career. And then, we can dive into some COVID-19 and how that relates to pulmonary and critical care medicine and also ECMO medicine that the United States Army is doing. Go ahead and next slide.
All right.
So, how did I end up in the U.S. Army? So first of all, went to undergrad in University of Central Oklahoma in Edmond, Oklahoma, which is a picture on the top left. And then after that, I got accepted to medical school at Oklahoma State in Tulsa, Oklahoma. And at that point, my father told me that he was no longer going to be paying for my my medical, scholarship, to include my mother saying the same thing to me. And so I decided, well, I don't know if I want to go into, $100,000, $200,000 loan. So let's look at different options. And at that point, started reaching out to different branches of the military. And once I got my acceptance letter to medical school, I reached out to the Army and just started discussing some things with them. So I was a traditional medical student at Oklahoma State. I wore traditional civilian clothes and did everything that my normal civilian counterparts were doing. And I was in the active reserve in the reserve at that point. So medical school didn't really look a whole lot different to me than a civilian. After I graduated Oklahoma State, I decided I wanted to go into internal medicine. So matched with the U.S. Army at Brooke Army Medical Center, which is the top right-hand corner photo there. That's Brooke Army Medical Center, and spent the 3 years there with internal medicine program. After that, I graduated, and the U.S. Army sent me out to become a flight surgeon at Fort Riley, Kansas, which is just right outside of Manhattan, Kansas. A lot of people think of a flight surgeon as somebody who is an actual surgeon. I am not a general surgeon, but is a term that we give in the military for medical professionals. So I worked with an aviation group and got to fly once a week. And in the bottom photo there is actually my good friend PA while we were in Afghanistan. He was doing hoist missions and practicing there. And so kind of the highlight of my career so far has been about 90 hours of Afghanistan flight medical en route care, where we actually flew around in the Black Hawk. Most of our missions were nighttime missions, picking up soldiers at the point of injury and also doing a lot of Role 1 to Role 2 transfers throughout that. So go ahead and next slide.
There you go.
Some people ask, how do you get into Army medicine? The most common pathway is actually on the right-hand side there, and that's through the Health Professions Scholarship Program. And so that's what I did. So most of our physicians actually go through that, and that's where they go through a normal medical career or medical school through civilians. And there's some highlights to that. My entire medical school was paid for. I got a stipend to live on, which at that time was about $1,800.
$800. Do you know how much it is right now, sir?
I think it's almost $2,400 a month to live on.
Yep, about $2,300 a month. Yep.
Yeah, which is amazing. My medical my students or my colleagues at medical school were struggling, drinking, natural light, and I was living the high life. I was able to buy a house in Tulsa, and so money was not a stress. And so you don't need more stresses than medical school alone. And then 2 weeks of a year, I was actually just got paid as an active duty first lieutenant during that time. And so it was extremely very nice option to go. The other option that, a smaller percentage of medical students will go through is actually going through the Uniformed Services University, which is on the left-hand side of your screen there. And they actually, and that's the Department of Defense's, that's actual medical school located in Washington, D.C. And so they're actually active duty during those 4 years. And that's a tri-service medical school to include Air Force, Navy, Army. And they are actually active duty, so they get paid $64,000 a year, active duty pay. All their medical schools paid for, of course, and then books, tuition, everything is paid for there. So those are your two most common ways to get into military medicine. The most common is the route I went, which is a civilian medical school, and then doing residency and any additional training in the actual military platforms, and then the Uniformed Services University.
Okay. So real fast before we switch, we have one comment real fast. Oh, we just got people saying, hey, they're following. Okay, awesome. Thank you. You want to go on to the next slide, sir?
Yeah, let's do it.
All right, next slide. Here we go.
A question that always often comes up is I don't want to join, so we're talking about medical students, and I go around the country trying to recruit medical students. And saying, well, I'm concerned if I join the military, I'll be limited in what I can do. So some of them say, well, I want to be a neurosurgeon, or I want to be a pediatric neurosurgeon. And so, this slide kind of outlines different training hospitals that the DoD actually have. When I say DoD, I say that stands for Department of Defense. And so in the U.S. Army, there's actually 7 different medical hospitals that we can train at. And so some pictures here is over on the left-hand side, we have a training hospital in Hawaii. So that's pretty cool. We have one in Seattle, which is the bottom left-hand corner. That's a beautiful Madigan there. Tripler is on the bottom right-hand corner down here, and that's in Hawaii. And so there's multiple different training areas that you can choose to try to match into. So about 7 different training hospitals that the Army can match into. And so not as many options as, the civilians, but you still have, quite a bit of different options that you can choose from. Washington, D.C. has Walter Reed, which is world famous. I'd like to say Brooke Army Medical Center is actually more famous now, but I'm biased, of course. And so there's a lot of different areas geographically that you can go to train. So, not as many as civilian, but still plenty different hospitals that you can train at. Let's go ahead and go to the next slide. And so the next question is, well, is the military going to say I have to go practice this unique type of medicine? So I've always wanted to be a pediatric physician, but I'm worried that the U.S. Army is going to say I can't do that because that's not a true wartime need. And so that's really not true now. And so you can match into almost every specialty that you could in the civilian world. So you can be a neurosurgeon in the U.S. Army. You can be a pediatric cardiologist in the U.S. Army. And what's kind of interesting with this slide that I'm trying to point out here is actually it is back looking over a 4-year period here, it was actually easier to match in a neurosurgery spot in the military than it was matching a neurosurgery spot in the civilian. So there are some unique areas that are higher are tougher to get into, and that's not surprising, right? Is emergency medicine. A lot of people want to be an emergency medicine doc in the U.S. Army. And then some of our trauma surgery specialties, those are in high demand too. But one of the things I often get is like, I don't even want to talk to you, Dr. Sjulin, about joining the military because I don't want the military to tell me that I have to be, an ER doctor and I really want to be a family medicine doctor. That's not true at all. You can actually choose, you go through a normal match that the normal military or your normal counterparts would be going through. And so that was the kind of the highlights on that slide.
Okay, next slide. Here we go.
So, wanted to talk about some of the unique opportunities the U.S. military, has given me. So up on the left-hand corner there is Afghanistan. So like I said, I got to spend 9 months in Afghanistan back in 2013 and 2014. I deployed as a flight surgeon there. And so we talked about that, over 90 hours of medevac helicopter flight time, which was just awesome. I wish we could go into some stories, but I know I have some family members on here that probably don't want to hear those stories.
This is true. I recognize that hospital on the right. I recognize it.
The one on the right is Landstuhl. So that is in Germany. And so as a as a resident, I got to go spend a month out there back in 2011. And that was a highlight because when a soldier, let's say a service member is a better term, when a service member gets injured in Iraq or Afghanistan, it is not uncommon that our transportation of that injured service member is so good that they will arrive at this hospital up on the right-hand side in Germany within about 24 hours of injury. So in 2011, I spent a month there in the trauma ICU. And unfortunately, in 2011, we were still kind of taking a lot of casualties down in Afghanistan and Iraq. And so we were quite busy, but that was so much fun. And then some perks with that is working, hand in hand with some trauma surgeons. But I also got to go ski the Swiss Alps while I was there. May have went to France. And so, unique opportunities that was all based on, I wanted to say thank you as a taxpayer because you paid for that. So appreciate that. And then on the bottom right, or the bottom screen is last summer, I got to go to Africa, to Ghana. And so, the military allows us to go out and do some of these, humanitarian missions. So, a lot of people don't think that is unique, but I wanted to pause here and say how unique that is, because for 3 weeks, with about, I think there was 30 of us throughout the country, we went to Africa, and we got to practice medicine and help with our Ghana National Army military there to kind of teach them, work next to them, and actually really do a great joint learning opportunity. And, that is so easy for us to do in the military because my pay doesn't change, right? So I still get paid, and I get to go do this. Now, that's so much different than a civilian doctor. So let's say I worked at downtown San Antonio Methodist Hospital. For me to tell them I want to take 3 weeks, or actually about 4 weeks off by travel time, right? I want to take 4 weeks off, Methodist, and I want to go to Africa and I want to do a humanitarian mission. Well, they're not going to pay me for that, right? Or they're going to say I have to take vacation time for that. Or if, let's say, I own my own business, I've got to shut down my office for 4 weeks. and where my secretary, my nurses, my techs don't get paid for. So it's really, really easy for us to go on humanitarian missions and not have to go through all the hurdles and hoops that you would if you're a civilian physician trying to do that.
Mm-hmm.
In the future slides, we'll kind of talk about that a little bit more. In a month, or I guess in a little bit of time here, I will be deploying to another location, which we'll put down in here, but we won't talk about that right now. But I'm with a field hospital as their pulmonary and critical care physician. So we'll be going down range again for a period of time, and so we'll add some more photos to that. So going
Next
to
slide.
another deployed. Yep.
Here we go.
And so these are just cool pictures. I apologize, some of the medical photos we needed to take out, but this is my first deployment in Afghanistan, and so this is just kind of lifetime friends that I met. We were there for football season, so on the bottom left here is me in my OU hat, drinking, I like to call it near beer or non-alcoholic beer. The funny story with that is there was OU Texas, so this is my PA, which is one of my best friends.
Mm-hmm.
He's a big Texas Longhorn fan, and so we were watching the OU Texas game back in 2013. And unfortunately, the Sooners lost to his Longhorns. And I think I must have drank 15 of those near beers. And I did not get any type of buzz, but I did pee a lot.
There
and
you
so
go.
it got all the negative of that. This is us flying around in Afghanistan, and I just wanted to show that there are some beautiful areas of Afghanistan. And then on the left-hand side here is a cool photo of me and one of my best medics. This is a intubation kit that we were going to use in case we needed to intubate, which is putting a breathing tube down in case somebody cannot breathe. And so we just had a lot of fun in Afghanistan. And so we'll go ahead and go to the next slide. These are just more photos of, lifetime friends. I mean, you get to spend 9 months with the same person. You get to eat breakfast, lunch, and dinner with them, and it's amazing the friendship that you can get. This is just my boss up on the left-hand corner. She's on the left-hand side. She's a cool ER doctor and a RAM doctor. So the U.S. Army allowed her to go get an aeromedical education residency, which is kind of what your astronauts get. So the Army let her go do that. Wow. And so that was awesome. So she may work for NASA in a couple years when she gets out. And then on the right-hand side, this is a cold December day medevac. And it was so much fun because it was almost like being a firefighter. You were right next to the helicopter. If you got a 9-line or a request to go pick up a service member, you had to be in your gear in the helicopter, and the helicopter had to be lifting its wheels off within 15 minutes. And so it was intense, but that was us getting ready for a mission there. And then the bottom left-hand corner here is a mission that we went on. That was a kind of a highlighted mission. We really, the crew did an amazing job of saving a service member on that mission. And so afterwards, we got together and took a photo with the OU flag. So that was a lot of fun there.
Awesome. We have a comment here. Okay. Let's take this off real fast. We got a couple comments. We've got a question from Kirk Taylor. How does one become a medical officer without any medical background? I am an NCO and want to do something that can transition to private sector.
Yeah, I think medical officer, I'd just kind of clarify that if he's wanting to become, our physician assistant. So I got to work with probably about 15 different Army physician assistants, and they all went up through the enlisted ranks and then transitioned over to PA school, and then, pinned on officer and became an officer at that point. So most of them were E5s, E6s, maybe even E7s by the time they transitioned over to get into PA school. And so that is one route that we see a lot. Another route that we see, I've had a couple medics that actually went to medical school. And so USHUS has a program where there's a couple different couple different ways that you can actually apply for medical school. through the program. There's green to gold, which is another option. For me, it was, a lot of some of the enlisted will go ahead and just, take all their credits for medical school. Then they'll go ahead and take the MCAT, which is the entrance exam for medical school. And then they'll apply for medical school. And once they have that golden letter of acceptance, the Army, you want to pay for this, and I'll give you some more time. Another option. Some of the other medical officers, another big thing that we see is the Baylor actually has an amazing MBA program that has a unique spin for a medical MBA component that's actually at Fort Sam at the schoolhouse. And so a lot of our nurses and some of our medical officers, non-physicians, will do that. And so that's another way to get advanced education. So I think he said, I'll delete I'll gloss over the LSU comment. I was actually in Atlanta for that beatdown.
Oh, goodness.
And so that was an ugly showing.
Let's get back into the slides, sir.
Okay.
We're going to hold off and have more questions and comments at the end. Okay. So we're going to jump into the next slide. Let's take off. First of all, let's go ahead and take off that comment about LSU real fast and talk to us about this, sir.
Yeah. So this is just what I wanted to kind of, show you here was just the amazing opportunities that you have in the military medicine, for example. So the top left-hand corner here is, this is our fellowship. So CHEST Foundation is the big foundation internationally for pulmonary lung doctors and thoracic doctors. And so every year there's a national convention, and we got to participate in a fellowship challenge. So all the fellowships throughout the world went through a tiering system to get into a final Jeopardy. And so there was 3 teams, and actually we won it all. So I just wanted to show there that, we do have some of the brightest physicians in the entire world in the military. And so that was a lot of fun. The top right-hand corner here is General Milley, getting to meet him and shaking his hand and getting a coin. So I could go on in stories of senators that I've met, famous people that I've met that come through our ICU, the generals that we meet, the Secretary of Defense. I taught him how to do a bronchoscopy one day, which is awesome. The bottom right-hand corner is me and Dr. Zanders, Tom Zanders. He's one of my many mentors, but one of the mentors that got me into pulmonary and critical care. He is now practicing up in Philadelphia. He reached out to me probably about once every month. We talk about cases and throw off different ideas. And so this is us at the CHEST drinking a beer, getting a mentor session. And so the military pays for me to go to all these conferences completely, free, and gives me a per diem. So that's an amazing benefit. The bottom left-hand corner is with some of my really good friends, the Kohlhoffers, and my father in the middle. And that's just to kind of show you that we get a lot of paid vacation in the military. And another unique thing is almost all of us work in big groups. So in my group is about 15 staff pulmonary and critical care physician. So it's really easy for us to go ahead and get off at the last minute to go to our kids' football games, our kids' sporting events, and then somebody else can cover down. So that's a awesome, unique benefit that we have.
That sounds excellent, sir. Let's go ahead and jump into some other pictures. Here we go.
Awesome. So some other unique opportunities with the military. So the top left-hand corner, I just wanted to kind of show you, this is a field hospital. So in September, I got to go out and got to spend 3 weeks in Fort Carson. And we set up a 148 bed ICU or field hospital, which is just amazing, right? So in this field hospital has 3 different operating rooms. So with this group, we had a thoracic surgeon, which we call a cardiothoracic surgeon. We had general surgeons, we had urologists, we had orthopedic physicians, we had anesthesiologists, we had internal medicine doctors that are all assigned to this group. And we're able to run a 80-bed ICU and 148-bed complete hospital. This hospital organization, which is the 10th Field Hospital, just got activated to go to Seattle to help assist with the COVID-19. Lucky enough for the U.S. population that when they got up there, the COVID-19 had slowed down, so they weren't needed. But we have good buddies that set up the 11th Field Hospital currently in New York City, where they're working out of a similar structure, helping out with COVID-19 in New York City. I just talked to Dr. Tyson Sjulin the other day, and he said they've got over 250 patients. 25 of them are in the ICU and just doing amazing things. So they got activated within, about 10 days. They were able to move all the way up to New York City and set up this hospital. The next on the top right-hand corner is just us working with our medics with some advanced management of hypoxemic respiratory failure, where we're actually proned a patient. That means placing a patient onto their actual belly so they could actually breathe better. On the bottom right-hand corner is back in Fort Riley. In the back, all the civilians there are, multiple senators from Kansas that we're talking to there, and we're showing them how awesome our medics are to save lives. Mm-hmm. The bottom left-hand corner is this picture of launch stool. So this is actually me presenting to a group of physicians in launch stool. And what was really amazing with that is in that group, we had 3 or 4 civilian surgeons that actually volunteered to help us out. So the lady next to me is actually a vascular surgeon out of Chicago that volunteered her time to come help us. Wow. And she was so awesome, well published, well known. And actually one night about 1700, 5 o'clock, one of the vascular grafts that was fresh on a patient popped. And so blood just went squirting everywhere. She was actually in the hospital, and we were able to save that patient's life because of amazing capabilities. Back in the backhand corner here is Dr. Fang, and he's world famous CCAT, which is Critical Care Air Force Transport Team surgeon that is wrote books and books. So got to work with him, right next to him in launch stool, and so just amazing opportunities. Okay.
You want to jump into? Let's talk about some of the humanitarian work that you could possibly do. Let's go into that. Awesome. So this is this is back last summer in Africa and Ghana. And so our mission there was actually pretty awesome. In the top left-hand corner, we were at the 37th Military Hospital. So Ghana actually had an Army hospital that we got to work in. And so for 3 weeks, we joined their team and we worked hand in hand with them. And so we got to teach them a lot of medical stuff that we had learned through the years. They taught us a lot of medical stuff. And so it was just one of the highlights of my career. So I worked in their ICU. I spent a lot of time. This top right-hand corner was something that, was unique because they don't have all the resources we do on a regular basis. So I'd actually taken an ultrasound machine over to Africa with me, and actually had taken a video laryngoscopy for difficult intubations with me. And so the ultrasound machine actually got me to be very famous. How so? Yeah, I was just kind of running everywhere. So the top right-hand corner, I was doing ultrasounds on pediatric patients. And so this young lady here, her oxygen levels in her blood were extremely low, and they just couldn't figure out what was going on. And her mom allowed me to take this photo. And so we did an ultrasound on her heart, and not being a pediatric physician, it was eye-opening. But we were able to figure out that she actually had a hole in her heart that was shunting blood from the right side to the left side. And when that happens,
your oxygen levels don't get very high because the blood bypasses your lungs where it gets filled up with oxygen. And so I was just bouncing from, all over the hospital doing all these ultrasounds. On the bottom right-hand corner here is I actually got to spend a lot of time in the operating room. And so this is their orthopedic surgeon. He called me from the ICU and he said, "Hey, we got this young soldier that has a foreign body in their hand, and I just can't find it." He said, "Hey, can you come over here with that fancy machine of yours?" And so this was us in the OR operating room, and we were able to locate the object in this service member's finger, and then with real time, just within a minute. He'd been in there for, over 30 minutes trying to find this blindly. And with the ultrasound machine, we were able to find it, pluck it out, and move on. Also got, and so that was just a highlight of the day. So the Africa mission was just a lot of fun. And once again, the military does a great job to make sure we have some free time. So during that time, I got to go on a safari. So we went up to North Africa and went on a safari. Also, we got to go to the rainforest and do some hiking there. And so it was just a really unique opportunity to do some amazing work there.
Let's jump into the next one.
So these are just more photos of the Africa mission. So this is just me teaching difficult airways to our local counterparts in Ghana. On the right-hand corner here, screen is actually a lot of fun. These two guys were awesome. These were anesthesiology residents there at the hospital, and so we were teaching them how to do scalene blocks for prolonged field care. We were teaching them how to do ultrasound-guided IVs. We were showing them how to do cardiac ultrasounds. We were just all the fun stuff. And so this is actually hands-on stuff that they were doing and doing all this. So we were trying, and so we had a lot of difficult ICU patients that we had there that we were able to figure out quickly. Sickle cell is unfortunately not uncommon over in Africa, and sickle cell just really can cause a lot of different organs to be affected. And so with ultrasound guidance, it was just so rewarding that these colleagues of ours, the first day they didn't know how to turn on the ultrasound. By the time I left, they were actually able to do cardiac ultrasounds and do all these advanced. And the big thing is they had ultrasound machines there. They had 2 ultrasound machines that we found in the closet for them that worked. They were actually better than my handheld ultrasound. And so by the end of the day, they were doing some amazing stuff and really just really changed their practice of medicine. The bottom right hand, these 2 pictures in the bottom are just a lot of fun. So this is an anesthesiologist, part of our team. And so we were going to the operating room. And so, they have some really challenging, medical cases in Africa, to include upper airway masses and deformities. And so, allowing a patient to have a breathing tube placed for surgery was sometimes extremely difficult. So this is in the bottom right-hand corner. This is us teaching them how to do a video laryngoscopy, which is kind of the standard of care now for intubation of patients in the U.S. So this is them doing that on a really critically difficult airway, and they were doing so well. And then the bottom left-hand corner is something that, anytime I go somewhere, I'm always trying to learn as much as I can. So this is our anesthesiologist here, and she's teaching me and teaching the rest of our colleagues in Africa how to do nerve blocks. And so not uncommon that in the military, we may get, sometimes we may have to do what we call prolonged field care, where we have an injured service member that may be in our little field hospital for multiple days to weeks, because it may not be safe to fly a helicopter in or out, or the Air Force may not be able to get in or get out. And so in those limited resources, you've got to kind of think outside the box. And so what I wanted to learn there was, in case we have a amputation of an upper extremity, and we've got to take care of that service member for a period of time, we don't want to just continue to use all our, pain medications because we won't get restocked. And so she's teaching me there how to do a nerve block. And so just unique skills that I would not get anywhere else, that we're just continuing to kind of talk and learn from each other.
Excellent. Let's jump on to the next one.
These are just a couple photos of the Black Hawk that we flew in Afghanistan. And so, this is just an opportunity to kind of show that, we're, a lot of advances in military and in medicine in general comes out of military medicine because of a deployed setting. So you go rewind, 15 to 20 years ago, tourniquets were not the standard of care for a civilian injury, but now because of the all the research that we've done in a deployed setting, tourniquets are the standard of care and they save lives. And so even in Afghanistan, flying in a Black Hawk, which most of our missions are nighttime missions. So we're wearing, nighttime vision. We would give blood. So we actually flew with blood in the back of the Black Hawk. And so, if a patient had been injured and, was bleeding out, we could stop the bleeding, and we could actually give blood in the back of a Black Hawk in the middle of Afghanistan in the middle of nighttime while you're getting shot at, which is just amazing that is advancing us to the level we are. I think Dr. Damon's online, so hopefully, good sir, we're going to have whole blood. We always give TXA, and we're going to throw a Robo in the next couple months. So
Excellent.
Next slide.
To some slides.
So let's talk a little bit COVID-19. So do we have a little bit of time here, good sir?
Yeah, we do. So,
COVID-19, I wanted to kind of talk about it not only, let's go over the general of COVID-19. So COVID-19 is a coronavirus. Coronaviruses have been around for a long period of time. So, and so what's unique about this one is it's just got a different RNA makeup than what we're used to. And so we don't have what we call herd immunity to this new one. And that's not uncommon, right? We see that every year or every 5 years with influenza, where we have some genetic changes in the virus, and that makes a new strain of virus that our body hasn't made antibodies to. What's really interesting with COVID-19 is not only is how quickly and how easily is it spread to one another, is how long it lives on surfaces. I think that's probably the thing that is causing so much problems with us, fighting COVID-19, is because it lives on surfaces for a prolonged period of time. So cardboard, it may live on a cardboard, your Amazon cardboard, for 24 to 48 hours. Unlike influenza that does not live on a surface for that long, or even like HIV, which is another virus that cannot live on a surface, but for only seconds or minutes, right? So that's why it's being spread so easily. The next thing is we are having so the people that get extremely sick with this, we're seeing that because the body is having such a huge inflammatory response to this virus. Mm-hmm. And so your body, all the white blood cells, all these cells that we love to have because they see things as foreign and they go destroy it. Well, when they do that, they release a cascade of inflammatory cytokines. And so those things are good. But like everything, if there's too much of it, it can cause extreme problems. Mm-hmm. And that's what we're seeing huge levels of inflammatory markers that are causing all these problems in the lungs and in the kidneys and in the heart. So that is a big problem. It also gives us some opportunities for targets, for treatment. So we've been given some targeted IL-6 treatment with some decent outcomes. But for right now, there's not an FDA approved medication for COVID-19. Early on, we had some hope that Plaquenil or hydroxychloroquine, which is a rheumatoid arthritis medication, was looking promising. but a VA study that just published in the last 10 days show that that did not help over placebo or doing nothing at all, and maybe some signal towards harm. Remdesivir, which is another antiviral medication, it looks like that data might not be as promising as we were hoping. And you know, that's that can be seen in some studies that are going to be coming out. So COVID-19, the big concern right now is, you know, another problem we're having with COVID-19 is a large amount of people are asymptomatic.
Yep.
And so you don't know that you have the virus, but you're that early on when you don't have symptoms, that's the time that you actually have the highest probably viral load, and you are spreading it among everybody. And so that's where some of the concerns about testing has come up. And so that's some unique things about COVID-19 on that level. We'll go on to the next slide to talk about more. As a lung doctor, as a pulmonologist, we have to talk about COVID-19 and how it attacks the lungs. And so, you know, COVID-19 is spread by droplets and not so much as aerosolized, which is a good thing because droplets only go so far. And you know, you guys all know that because that's where that 6 feet of distancing comes from. And so, you know, COVID-19, you know, affects the lungs, and it affects the lungs like things we haven't seen in a while in the degree of inflammation that it's causing the lungs. And so it's been a unique challenge. At first, we were trying to intubate these patients really early on in their course when they were needing only 6 liters of nasal cannula. That came back and backfired on us, right? Because we really realized quite early that you can run out of ventilators in the U.S. So New York was running out of ventilators, right? We were trying to figure out, can we ventilate 4 patients with 1 machine? And so the thought with that was, if you can go ahead and put a breathing tube down their lungs, then we could potentially, you know, not spread the virus as much in between healthcare workers. Mm-hmm. So that's why we were doing that early on. You go back to early March, that backfired on us. And so now what's kind of interesting is it's changed the way we practice medicine. And if you're reading the literature, you'll come across this term called the happy hypoxemic patient. And hypoxemia just means that your blood levels are low in oxygen. And so, you know, if you go back, you know, 3 months ago, if your oxygen levels, let's say on a pulse ox that you get, you know, that you can buy at Walgreens, if that was below 90% and you were getting a large amount of oxygen support, we would probably go ahead and put a breathing tube down you and put you on a mechanical ventilator. But with COVID-19, we're seeing a large amount of patients that are actually able to have low levels of oxygen, but still be without severe shortness of breath and without any end organ damage. So it's been a very unique, you know, disease that has really made us, you know, question some of the things we were doing early on. And what's kind of fun is, if you guys are on WhatsApp, the U.S. military is actually, we have got 140 tri-service critical care pulmonologists, infectious disease, hematologists, all on one WhatsApp, and every day just sharing best practices, everything that we can come up with. So, you know, yesterday we were talking about taking blood from patients who had been exposed to COVID-19 and had been recovered, and they had all these antibodies, and so trying to get plasma exchanges, and so everybody's working together to try to do that. They've done it down in Keesler. They're looking to do it up in Ohio. Everybody's just sharing best practices and not so best practices in a DoD entire military you know, group, which is just a lot of fun to see all this that's coming up and being spread.
Let's go ahead and jump into the next slide.
This is just how are we doing on time, good sir? About 15 minutes?
Yeah.
Okay. This is just kind of a unique slide to kind of talk about, you know, oxygenation and how to do that. The other thing that this is really challenges on is how do we set up our delivery of medical care to expose the least amount of healthcare workers that we can. And so, unfortunately, COVID-19 has just been devastating for healthcare workers for morbidity and mortality, unlike any other virus that we have really seen. And that is dangerous. That if you start, infecting all the healthcare workers, then who's going to be there to take care. And so we've had to really work, in a group setting to kind of work with how do we set up our mechanical ventilators that we have different filters in line so we prevent the spread of the virus to the local environment and between healthcare workers. And so these are just kind of unique things that we continue to work with. And so now instead of intubating those patients early on, we're allowing those patients to wear high flow nasal cannula, which is a nasal cannula that goes in your nose, where we can give very high levels of oxygen flows. Where that, if you go back to early March, that was like, do not do that, because we were worried that high flow going through your nose was spreading particles everywhere. But now, over the last 3 weeks, people have been like, let me question that, right? And so studies have come out and say, no, really, it doesn't spread viruses any more than a regular nasal cannula. Mm-hmm. So, just like deployed medicine has really allowed us to increase our knowledge in medicine in general, this COVID-19 has actually allowed us to really, challenge and come up with some innovative things to change the way we practice medicine. So in a positive, spin when it comes to that.
Well, let's jump into the next one.
I think that one thing that really got us concerned early on was how are these patients dying from COVID-19? And it seems most patients are actually dying from heart failure. And so that was a unique thing that we were seeing, that, COVID-19, because, lucky enough, the infection that happens in your lungs, we can usually, with COVID-19, with good mechanical ventilation support, we can keep your oxygen levels up to a decent level that we can sustain life. These patients usually have what we call pretty good compliance when it comes to lungs, means that they inflate and deflate normally, and so we can actually oxygenate them pretty easily. And so why were they dying? They're dying at 10 to 14 days of their ICU length of stay, and they're dying because of bad rhythms of their heart, and also because of heart failure. And so what's been interesting is everybody's trying to figure out is what's going on, and is this virus actually invading the heart muscle itself? And at least out of the autopsy results that have come out of China and the ones we've seen so far, and talking to our cardiologists throughout the military, it really doesn't seem to be directly invading the heart muscle. It seems to be that extreme inflammatory response that the body's doing is causing that heart failure, but not directly invasion of the virus into it. And so, unfortunately, a study that came out yesterday, when the COVID-19 patients that are actually being put on a mechanical ventilator, unfortunately, those numbers do not look good, as in about 90% of those patients will end up dying. We just started sharing our data with the military last couple of days, and our numbers seem to be quite a bit better than that. But we're not seeing the level of COVID-19 patients that some of these other centers are seeing throughout the U.S. But we're seeing probably about 50% are able to actually be removed from the ventilator and able to survive their ICU stay. So there is some promise there.
Okay. Well, sir, we got one more slide for you, and it is questions. Let's go ahead. If you all got any questions or comments at all, please feel free to comment on our sections there. It looks like we got two.
Yep.
Let's add them. We've got Captain Weaver. How you doing, Captain Weaver? And she says, so awesome that y'all are doing this. Thank you. And she says also really good information about COVID-19. I think you've done a great service with this presentation. Why? Because you're not only painting the picture, a realistic picture of, join the military, being a doctor, still being able to have a life, live a life, have a family, etc. But also you're at the forefront of what the Army's response to the COVID-19 situation. Now you have kind of, from what I know, you've kind of under painted yourself as far as your role with our Regent Hospital. Can you tell us about what you do for BAMC and its response to COVID-19?
Yeah, I unfortunately, because of my upcoming, deployment, I have been asked to stay at home so that I can deploy in a couple in the near future, I will say. But our team back at BAMC really is leading the way when it comes to the joint effort there to discuss the day-to-day planning of COVID-19. I was part of that early on training before I was asked to leave, so I didn't get infected. My partners did not want to take my spot in my deployment, so they told me to go home. But really a unique deal. And so, every day they're huddling twice a day with a group of infectious disease doctors, critical care doctors, internal medicine doctors, and working through just how do we set up the hospital, right? Yeah. And so unique in the fact that we had to, isolate COVID teams. So a group of physicians, nurses would actually just be isolated to one ICU. So we closed down our critical care unit. We made that into a COVID-19 unit. So a 10-bed ICU that everybody that worked there were isolated. We isolated equipment there. So the ultrasounds, the radiology, that all stayed on that one unit so it didn't cross-contaminate the rest of the hospital. And so you're coordinating stuff like that. You're coordinating with pharmacy to see if you can get these medications. You're coordinating with the local hospitals throughout the local area to talk about, how do we share resources? Fortunately, thanks to taxpayer money, we had the best equipment we can. So we actually have 140 mechanical ventilators at BAMC, wow, which is awesome. And then, if we reach out to the Air Force over at Lackland, which is in San Antonio, with their critical care Air Force transport team, they had another 20 or 40 mechanical ventilators. And then Fort Hood had another 50 mechanical ventilators. So we're able to kind of, start game planning about how are we going to use resource management. And so it's been a lot of fun when it comes to the quick response to work as a multidisciplinary team. And so those are the things that, you continue to work with. And then you're trying to also try to figure out, a lot of us are actually assigned to different field hospitals. So for me, I'm assigned to Fort Carson, which is in Colorado. And so they, when we got those orders to deploy within, days to go up to Seattle to set up that field hospital, that was a huge, unique challenge because we lost probably about 5% of our physicians. And we lost, 15% of our ICU nurses that were going to be, positioned from Brooke Army Medical Center all the way up to Seattle. And so you're kind of working through that and game planning, and so it's a lot of unique challenges that come into that on a day-to-day mission. And those things continue to change because every huddle, we're trying to do as good as we can about modeling, about when do we think the peak is going to happen. And then, also trying to strategize where not everybody's at home, right? Or not everybody's at work. And so for week one, you may only have 20% of your doctors in the hospital. The rest of them are at home doing telemedicine. But what you don't want to do is you don't want all your doctors being exposed to COVID-19, getting sick. Yeah. And so you're trying to strategize about your tiers. And then lucky enough for us, some of our retired physicians that have come back, 06 as they're retired, that maybe that are over the age of 50. We've been very lucky that we put them on an outpatient rotation, and so they're at home, and so they're not being exposed to COVID-19. So some of the unique things that we get to work through on a day-to-day basis.
Excellent. So I got one more question from Latasha. She says, how do you maintain balance? How do you maintain balance?
Yeah, I actually think that the military actually allows me to have a lot of balance. Burnout as physicians is really a high concern. So a critical care physician in the U.S. is about a 50% burnout rate. And so it's, I'm still pretty young, but, you look back at my medical school class, and there might be 10 to 15% of those physicians that have gotten so burned out in medicine because of different issues that we won't go into, that have quit medicine altogether. Wow. And for me, I've seen burnout a couple times in my career, but I just kind of raised my hand and I went and did something a little bit different. Which is awesome. You can go more administration if you want to do that, more of in charge of a clinic, in charge of a hospital. You can go do more research. You can actually go do teaching at the medical school. So there's a lot of different opportunities to kind of help help prevent burnout by doing that. The military actually gives me a whole lot of free time. I get 30 days of paid vacation a year, which is amazing. And then, Friday afternoons during football season, I usually head out early to go to drive my RV up to the OU games. And I just have my colleagues cover that. So there's actually a whole lot of time for balance. And because you work in big groups, having somebody cover down for your clinic so you can go to your daughter's medical care or medical appointment is really, really easy. And so I think balance is actually something that the military has actually allowed me to have even better balance than I would as a civilian pulmonary and critical care physician. So great question. Great question.
Oh, awesome. Do we have any other questions coming in? Any other questions at all? Going once, going twice, sold. All right. Well, sir, Dr. Sjulin, we really appreciate you, coming and talking with us. I would say come on back next week and let's talk, but I know you're a busy man and getting ready to go to an austere environment and do your duty.
Well, thank you for having me, sir.
All right. We appreciate you and you take it easy. All right.
Thanks, sir.
All right. So, as I always say, there's a great opportunity for you to, if you want to learn about Army medicine, if you want to talk to one of our virtual recruiters, and all of our recruiters right now are virtual. You could give them a call, you could do video teleconferencing, etc. You can contact them. And if you're looking to get in contact with them, you go on the website, healthcare.goarmy.com. I'll say again, healthcare.goarmy.com. You could follow me on social media, on LinkedIn, Instagram, Facebook, and Twitter at 5th Medical Recruiting Battalion. I'll say again, 5th Medical Recruiting Battalion. If you're looking for more information on joining our team and you want to get your school paid to go to med school, let me know. We'll square you away, okay? So I say in parting, take care of yourself, take care of your family, and take care of others. Y'all take it easy.